especially had I believe about everybody showed up. So this is great. It's going to be a great day. What we do on Grand Rounds on interview day is have a couple of our residents present cases that they have found of interest in the last few months or so on services, sometimes in the last week, but we'll see what they are. Just so you know, for the rest of the day, and maybe Cindy's already told you, which, by the way, she's standing back there. Raise your hand, Cindy. If you have any questions today, she's the person to ask, okay? I realize it could be somewhat confusing. But once we have Grand Rounds, because we have a big stroke education program following us, we'll have to go back upstairs to the 4th floor for an hour or so of orientation, and we'll get started on interviews. Hope you all were here last night and enjoyed your time with the residents. And if you don't already know it, that's the way to find out about a program, not from the rest of us as much as them. Today, a couple of residents are going to present cases. Both of them happen to be native of the Chattanooga area, Laurel Barnes and Sean Forrest, and we were able to get them back here for their education. So we'll get started. You going first, Laurel?
Good morning. Welcome to Chattanooga. I just have a couple pictures up here that show you some of the camaraderie amongst the residents. Chattanooga is a great place to live. There are a lot of things going on all the time, a lot of music festivals, a lot of sporting events, triathlons, marathons, bike races. Me personally, I like to spend a lot of time outside. I do a lot of hiking and as much as possible during the summer, as much water skiing as I possibly can. But I wanted to talk to you this morning about a case that I found pretty remarkable that happened a couple months ago. For me, I went into surgery because I love the way, as a surgeon, you can actually change the trajectory of a disease process and change the outcomes a patient might have. And this case truly epitomizes that for me. So a brief outline, we'll start with a case presentation. The patient initially sustained a pulmonary embolus. So I'll talk a little bit about PEs and then as well about CPR. To get back to some surgery, I'll talk some about liver injuries, which the patient sustained, and then finally a little bit review of cost of medicine. So history of presenting illness. An otherwise healthy 49-year-old female had chest pain and a syncopal event early one Sunday morning. This was witnessed, and the witness called EMS, and they brought her to the hospital. As she presented to the ER, she had altered mental status and came in screaming of chest pain. In the ER, she became increasingly bradycardic and finally arrested. CPR was performed, and the gas is shown here that was obtained upon presentation. As you can see, she has a pretty profound respiratory acidosis. Her lactate was nearly 13, and her hematocrit was normal. After return of spontaneous circulation, they got a rhythm of AFib with RVR. Cardiology came to bedside and performed an echo, during which they saw right heart strain and what appeared to be an empty LV, suggesting that she had PE. She coded some more. CPR was performed again, return of spontaneous circulation. She was intubated, and they took her over to CT while on pressors to obtain the imaging shown there. They reviewed the imaging and saw that CT had no intracranial hemorrhage of her head. The PE protocol showed pretty large clot burden bilaterally with right greater than left. And again, a repeat ABG was collected. At this point, her lactate had increased to nearly 18, and her acidosis had worsened. Medical ICU team arrived, and they started her on TPA, having reviewed those two images. And then cardiothoracic surgery came and cannulated the patient for ECMO. At this point, the radiologist called over to the emergency department and said, "We have an emergent finding of large volume hemoperitoneum." So consequently, trauma surgery was then consulted. We obtained a bladder pressure because of concern for abdominal compartment syndrome, and it was remarkably high at 68. As you know, the indication for to move towards surgical intervention is 20. So at this point, having been on TPA and ECMO for a couple of hours, her right heart strain had improved. And so Dr. Pointer, cardiothoracic surgeon, and Dr. Maxwell came up with a collaborative plan to take the patient to the operating room, decannulate her, and try to reverse her coagulopathy and proceed with an exploratory laparotomy. I'm going to go through her imaging of her chest, abdomen, and pelvis. This is her CT of her chest. You can see some contusion in sort of the mid-chest. And then as we go through the PE protocol, you can see, I'll show you here. Thank you. You can see here large volume clot on the right, and then over here there's a less profound burden, but also left-sided clot. And then as we go down into the abdomen, if you look carefully, you can see some blood around the liver, and then here in the middle of the liver, you see contrast refluxing into the liver as a result of the large right heart strain and increased right ventricular failure. Additionally, there is some blood in the pelvis, which is less clearly demonstrated. So the patient was decannulated and protamine was administered to reverse her heparin, and then we performed a midline incision. There was release of blood with the blood shooting several feet up into the air. At this point, she did have a reperfusion event and became profoundly hypotensive. We performed aortic compression initially manually and then with a compressor device while anesthesia caught up. After she had return of strong circulation, we began to explore the abdomen. The spleen was noted to be grossly intact, and we saw that there was a lot of retroperitoneal hematoma on the right side. So we performed a Cattell-Brash maneuver, or a right medial visceral rotation. We inspected the kidney pretty closely, but we didn't actually see any injury over here. So we proceeded to pack the renal fossa and then moved on to the liver. There was a grade 3 laceration of the liver where the falciform entered. We attempted to ligate this initially with 2O silks. That didn't work very well. So then we closed the liver laceration using a zerochromic on a blunt tip needle using rolls of Surgicel as pledgets. This slowed the bleeding, but it didn't get total control. So we then placed a zerochromic suture U-stitch at the base of the laceration. And then after this, we applied Everest topical thrombotic agent to the defect and packed this with laparotomy pads. We continued to run the small bowel and the colon. We didn't find any further evidence of injury, and at this point we felt there was no further surgical bleeding that we could address, and so we made plans to transfer the patient to IR. We were obtaining TEGs throughout the course of the operation, and I'll talk about those in a minute. So as we waited for IR to be in-house and ready to receive the patient, over the ensuing 45 minutes, she showed signs of recurrent abdominal compartment syndrome. Her end expiratory pressures increased and increased until they were quadruple what they were early on. Her ventilation volumes fell off, and her saturations dropped from 100% on 21% FiO2 to 74% on 100% FiO2. And she again became pretty hypotensive. At this point, we decided we had to go back into the abdomen to address the recurrent abdominal compartment syndrome, and so as her abdomen became increasingly protuberant. This is a picture of our patient. This is actually the following day on return to the operating room, but you can see here the profound distension of her intestines coming out of her body. So we continued to explore the abdomen. We reprepped and draped and put the book-Walter back in place. And at this point, it looked like there was some blood in the lesser sac. So we opened this. We were concerned that maybe there was some blood coming up from around the pancreatic neck. So being concerned that maybe there had been some aortic injury from the early compression, we proceeded at this time with a Maddox maneuver, or a left medial visceral rotation. We didn't find any gross source of bleeding in this area, but we did find some oozing, which was controlled with stick ties. And this time we returned to the right renal fossa where we had seen the bleeding earlier and noticed that there was continued ongoing bleeding in this area. We developed a space between the aorta and the IVC and found a 5-millimeter hole at the confluence of the IVC with the right renal vein. We closed this with a 3O proline and also found a bleeding area on the back of the vena cava, which we were able to control with a tube tie. The liver at this time was more hemostatic than it had been earlier. So the abdomen was repacked and the temporary abdominal dressing were placed, and at this time we were finally able to transport the patient to IR. during IR, they were able to identify a hilar vessel which was bleeding and embolize it, and I'll show you that imaging here. And then after that, she was transported to the ICU. All these things you see are the lap pads which were left packed in the abdomen. You can see the catheter coming up for the aortogram shown here. And then we move towards the right renal arteriogram. Over here, you see an area of active extravasation. And I'm going to just go back up to this. You may notice that having mobilized the kidney, we left it rotated medially, so it's in a different position than you would usually expect to see the right kidney. And you can see here the coils with which they were able to embolize the bleeding vessel. And then finally, here in this set of images, there's no further active extravasation. This is her first tag obtained as we started the operation. And the overall picture of this tag is that she was severely thrombolytic. On the right, you see a ideal tag and also some of the indications, the things that you can detect using tag. The amplitude of the curve shows you something about the maximum clot strength, and as you can see on our patient, the amplitude is tiny. This was clinically reflected in the fact that throughout the entire first operation, we saw no clot. Additionally, you can see thrombolysis as a result of a good clot that is not degrading will stay approximately horizontal going across the screen, and our clot completely degraded and came back to baseline at 0. She had 95% lysis of all clot that was formed, and her amplitude is only 3.6 as opposed to the goal of 50 to 70. After some time, having been on a TXA drip, this tag was performed, and you can see it's pretty profoundly different. Nevertheless, it is still abnormal. The angle of the curve shown here should be pretty steep coming up. And as you can see, ours is quite flat. This reflects that the patient was in desperate need of clotting factors and PCC. Notably, early on in the course of the patient's massive transfusion protocol, PCC had been absent from the blood that they were sending up to us. So when this tag was obtained, we contacted the blood bank, and they were able to send us not only the indicated PCC for the ongoing rounds of massive, but they were able to make up the earlier PCC, and we were able to correct the coagulopathy, so that by the middle of the second operation, she was actually forming clot. So in total, the patient underwent 8 rounds of massive transfusion protocol, as shown here, and she had 34 liters of blood loss to the suction devices only. That does not include the losses to the floor as well as the losses to the innumerable lap pads. In addition to all of the blood products, she also had these hemostatic agents administered. She had protamine early on, as I mentioned, and TXA drip. She also had 4-factor PCC, or Kcentra, and then we used both Everett mesh, which contains thrombin and fibrinogen to enhance clotting, as well as Surgicel, which is just a platform to help trigger clotting. So pulmonary emboli. The incidence of pulmonary emboli has increased over the last 25 years from 23 to 65%, and the number of those requiring hospitalization has also increased. Overall, there's a 10% 30-day case fatality for PEs and a 23% one-year mortality. However, those numbers, not surprisingly, are less severe for those who are hemodynamically stable at presentation, and there's 65% mortality for those who present requiring CPR. You can see, as we all know, a lot of the risk factors are things like immobilization, but one study found that of the patients that they found with PE, 27% of those patients had PE within 10 days of a major operation. Treatment for PE, standard of care is a heparin drip, but thrombolytics are increasingly recommended for massive PE. This is our patient here on this side in the coronal views, and you can again see the right-sided near-occlusive thrombus as well as some intermittent thrombus on the left. And ECMO over the last 10 years has been increasingly recommended for those who are not responding to standard therapy or as a bridge to embolectomy. Indications for thrombolytic treatment are hemodynamic instability and right heart overload, both of which our patient had. Notably, right ventricular failure, as I showed you earlier, and you can see here as well, leads to reflux into the liver and hepatic congestion and consequently subsequent enlargement. This study reviewed all the patients who had ECMO over a 2-year period at a single institution, and they found 5 cases of ECMO utilized for severe PE. In 4 of those 5 patients, CPR had been performed prior to cannulation for ECMO. And this case series had a 40% mortality. This is similar to mortality for those treated with embolectomy and TPA taken all together. However, if you recall, the mortality for patients who have had cardiac arrest is actually higher. It's 60 to 65%. So overall, there is likely a survival benefit for ECMO in patients who have had massive PE, especially in those status post cardiac arrest. Dr. Pointer, the cardiothoracic surgeon involved in this case, and I spoke on multiple occasions about CPR as the likely etiology of this patient's liver laceration, and he pointed me towards this article. This came out in September of this year in JAMA Cardiology, and they talk about the combination of ideal compression rate as well as compression depth and the results on survival. The ideal depth of compression is 4.7 centimeters, plus or minus 20%, and the ideal rate is 107, again, plus or minus 20%. And for those that fall within these parameters, there's a 1.44 odds ratio for survival. The paper talks about how the increased rate likely results in worse outcomes because of decreased depth that results, but they don't really define why the increased depth results in worse outcomes. But having had several conversations with Dr. Pointer, I was left wondering if it was because of increased visceral injury. So I went looking for injury results following complications of CPR. I thought this would be useful information for those who are having conversations with family members about DNR, DNI status, and goals of care. Not surprisingly, the highest complications are some skin changes, but these are the ones I thought were more important. 30% of patients sustain rib fractures and 20% sustain sternal fractures. Over here on the right, 11% have some sort of aspiration event, and 45% have pulmonary edema. And then up here in green is our patient's complication, a liver rupture, which happens in 2%. Altogether, I had never really tried to come up with some numbers, but I did find these surprising. Only 26% of patients who undergo CPR survive to hospital discharge, and patients with good functional status at hospital discharge are a mere 16%. So specifically looking at liver injury after CPR, I was surprised at the number of papers I found. This paper looks at nearly 2,600 cardiac arrest victims, and in 15 cases found major liver injury. 9 cases were found with ultrasound, and 8 of those had free intraperitoneal fluid. An additional 6 patients were found at autopsy. 13 of these 15 patients had compromised coagulopathy, and only 2 of these 15 patients survived. I personally thought it was interesting, because this was the topic I was in studying, that 2 of the patients had CPR following PE events. The paper indicates that most commonly injury to the liver is injury to the left lobe, and they posit that perhaps this is due to inappropriate hand position during CPR. So now some words about hepatic trauma. Much of this is not surprising. Obviously, you can use compression, electrocautery to help control hepatic bleeding. But the Pringle maneuver is something that we often talk about, which is occlusion of the portal triad at the foramen of Winslow. This can either be performed manually or with a compression device. Here on the right, we have a picture of omental packing into a liver laceration. This is not our patient, but this is another one of Dr. Maxwell's patients. You can see the omentum packed in and then the liver laceration closed over the omentum. And some words about grade 5 injuries. So the primary way to address grade 5 injuries is to use total hepatic vascular isolation in order to get control of the bleeding in order to address the injury itself. So how do you do that? There are 4 points that you have to get control of the vasculature. First of all, at the portal and hepatic arterial inflow, you have to get occlusion, i.e. the Pringle maneuver. You have to get infrahepatic cable control as well as suprahepatic cable control. Suprahepatic cable control can either be performed above or below the diaphragm, and then you also have to get aortic occlusion. This maneuver can also be referred to as the Haney maneuver. This is particularly useful in retrohepatic injuries such as IVC injuries or hepatic vein injuries. And notably, once you are moving towards this kind of maneuver, you have only about 15 to 20 minutes in order to accomplish your repair before the ischemia to the entire lower half of the body simply becomes too profound. These are some more pictures of similar things. Another picture of the Haney maneuver shown here. This one does not show the aortic occlusion. And then here on the right, this is the only picture I could find of this procedure, so I'll explain it to you. Here you can see on the outline, this is the laparotomy incision with some clamps, retractors holding it open. And then in dark gray is the diaphragm. And then we have the penciled in, sketched out heart above the diaphragm, and you can see the liver here. In order to get supradiaphragmatic control, you can either do a thoracotomy or you can do this maneuver where you open the diaphragm and the pericardium to get control of the IVC above the diaphragm. So, as part of our presentations, we like to always talk about the cost of medicine so that we're aware of that as we think about decision making. So having had this patient who required a lot of hemostatic agents, I wanted to just cover some of those. Protamine costs about $151. TXA bolus, which the patient started with, is nearly $50, and then an infusion, which she was transitioned to, is about $70. 4-factor PCC, or Kcentra, is nearly $7,000. Patient also has some hemostatic materials that were used during the surgery. Surgicel, a sheet of Surgicel, approximately 4 by 8 inches, costs $55, and a 2 by 4 piece of Everest costs $775. So how did the patient ultimately do? It was pretty remarkable. The same evening of her index surgery, she was actually obeying commands on 4 extremities. Over the course of her hospitalization, she returned to the operating room 6 times for reopening of recent laparotomies, washout, and eventual abdominal wall closure. And she was able to be discharged to inpatient rehab on post-op day number 37. She was discharged on Eliquis and aspirin. She spent about 2 weeks in rehab and then was able to be discharged home, and she's reportedly doing well at this time. I'd be happy to take any questions. These are my references. And I wanted to say special thanks to Dr. Maxwell and Dr. Pointer for allowing me to participate in this truly remarkable case.
Do we have any idea what was the etiology of her pulmonary embolus?
We don't definitively know. I personally believe that the etiology was a familial coagulopathy. Her father told me that he had had a DVT event when he was a young adult. She had not had any recent travel or any other risk factors to speak of. She was African American, which has a slightly higher risk, and on contraceptives, but nothing else very notable. She has not been able to be tested for that because she remains on anticoagulation.
Yeah, but, I mean, eventually you're going to need to test her for factor deficiencies, yeah.
Yeah, I think she probably has some kind of familial hypercoagulable condition. Nice job, Dr. Barnes. A lot of interesting topics came out of that case. And I'd just like to emphasize the reason, she was so coagulopathic was she got a full therapeutic dose of TPA when they diagnosed the PE, and then when he went to put her on bypass in the emergency room, he gave her 10,000 units of heparin. And so between the TPA, the 10,000 units of heparin, and having all that portal congestion from the right heart strain, it was just an absolute bleeding nightmare. From the liver, it wasn't a bad liver injuries type of thing. You can usually just pack off with laparotomy pads, and it's not going to be that big of a deal. And I guess she had this injury in her vena cava right where the right renal vein comes off, and so he blindly cannulated her in the emergency room with a femoral drain, and he may have had a catheter injury. And there was some kind of arterial bleeding from the kidney. I mean, we had the kidney completely mobilized and just looked at it and looked at it and looked at it, and we could not find whatever they wound up embolizing. I mean, I'm kind of embarrassed about that, but I mean, we looked until my eyeballs were about to pop out of my head, and we just couldn't find anything so we had to bow our heads and go to IR for that. But, what really happened that pulled us out of the ditch was they got the tag, and the person in the blood bank called their supervisor at home and said, I don't know what's going on with this tag. I've never seen anything like it, and that's like the most ridiculous tag. It's a knot tag. And she realized that the patient was profoundly hypofibrinogenemic, and they just started shipping all this cryo up there. And until she got the cryo, it was just a blood fest. And we got some cryo in her and got her fibrinogen level back up. It seemed to calm things down. We didn't have a grade 5 liver injury, but Dr. Barnes put that in there because that's an oral board style question. How do you do total hepatic isolation for a grade 5 liver injury? And those pictures explain it. So that's something for the chiefs to try and retain for potential questioning later.
That is, this management of this coagulopathy is a good example of a surgeon as an internist who's finished the training. Dr. Stanley.
Yeah, just a quick question. When I was in training, we would do the Trendelenburg procedure where they actually did a thoracotomy. They did an embolectomy of the pulmonary artery. Is that pretty much just a dinosaur now and never used, or is there any case where you do that?
I'll answer that for you. The case why she didn't have it is because she improved on the ECMO. They were able to get flow back because the pump was there. But within the last week, our other cardiothoracic surgeon came down to the lounge and had a clot probably 12 inches long that he had pulled out of somebody's lung. So it's still done. It's just not done nearly as frequently as the literature shows us.
Mortality rate's extremely high for that particular procedure, but then it's John, you want to turn my volume down some, please. Anyway, I think the Trendelenburg procedure is still done, but rarely so, especially in view of what our vascular surgeons are doing in terms of clot lysis when you can.
It's still done on Grey's Anatomy.
Yeah, there you go. Yeah.
But when she got stabilized with the ECMO, she was so bad off from her abdominal bleeding that wasn't really even on the table for discussion at that point. She needed a laparotomy.
Well, you and I had a case of this with one of my children who had a big pulmonary embolus post fracture repair. And one of the things to mention about doing something about the clot, because he was not this sick, but lysing his clot probably saved him from being a pulmonary cripple long term, because you do end up with problems with that. And so lysing the clot is an important thing in terms of not getting stuff into right heart failure with fibrosis of the pulmonary artery. And in his case, he's a very vigorous, healthy 40-year-old now instead of a pulmonary cripple. So. Yeah, Dr. Green.
Yeah, I was just going to make one point about that. The submassives are the ones that we sometimes will do a lytic place a catheter into the pulmonary artery and drip TPA. So those are good cases, but they're the submassives, not the ones who are resting. These are tachycardic, a little shorter breath. They got the right heart strain, and you probably do save them acute resolution of their symptoms and maybe prevent them from having pulmonary hypertension as they get older. So we do use that sometimes. It's kind of selective, but again, it's submassive, not the massive ones.
One more quick comment. One piece that fell in place that helped save this lady is somehow, was this a Saturday or Sunday afternoon?
It's a Sunday.
Sunday afternoon, they had cardiology down in the emergency room doing an echo on this patient. And if they hadn't gotten cardiology down there, I think they're the ones that had the sense to call cardiothoracic and cannulate it. Did the ECMO in the emergency room, which, let me tell you, there's a lot of hurt feelings down there. When they just came down there and put that patient on bypass, all those nurses were still upset about that. But
Well, saved her life, though. Be interesting, I think, for long-term follow-up, Laurel, to see what happens with her in terms of the coagulopathy defect that she probably has. Dr. Forrest, that was a great case. Dr. Forrest. Is this a picture of Chattanooga?
No, sir, it's not. So today I'll present an interesting case of pneumatosis. I know Dr. Barnes kind of welcomed y'all to Chattanooga, but I'm biased, but I think it's a great place to live and to train. I'd like to thank Dr. Mejia, who was the advisor for this case, or for this presentation, and the attending surgeon on this case, and then also one of the chief residents, Dr. Johnson, who participated in this case as well. I have no conflicts to report, so we'll start in a similar format with a patient presentation. So MW is a 54-year-old man who presents with a 12-hour history of acute onset left flank and left lower quadrant abdominal pain. He has had 7 episodes of painless hematuria. He reports that his most recent bowel movement was earlier that day. He denied that it was bloody. It was also painless, and he's still passing flatus. Now, as far as his past medical history, it's only significant for asthma, hypertension, and then history of opioid abuse, currently taking Suboxone. Past surgical history only significant for a left total knee replacement. As far as his home medications, he takes aspirin, just at 81 milligram, because he heard that it was good for him, albuterol, amlodipine, Suboxone, and rosuvastatin. Of note, his family history includes maternal gastroesophageal cancer at age 74, no family history of colon cancer, and he has a sister with rheumatoid arthritis and a father with Sjogren's syndrome. He's a 1.5 pack per day smoker, and overall he had a smoking history of 40 pack years. So then moving on to his physical exam, he was had a normal temperature. He was tachycardic and irregular, and then when you evaluated the monitor, he appeared to be in atrial fibrillation, which was not a known diagnosis of his. He was in no acute distress, cleared auscultation bilaterally, moderately tendered a palpation in the left upper quadrant, did not have rebound. And then as far as his laboratory evaluations, his white count was 13,000, hematocrit was 41,000, creatinine 1.2, and lactate 1.21. So we'll go through his CT scan, try to get through this relatively efficiently. So just based on this initial plain film, this is a scout film, but you see significant abnormality up here. in the left upper quadrant. And then going through his CT scan, you see that he has colon back here, and still a very irregular colon, and then the appearance of pneumatosis. So it looks like there are these cystic kind of projections within the wall of the colon, which is quite impressive. And then continuing down, one of the important things in a patient like this that you'd like to look for is other evidence of intestinal perforation. So if there's significant free fluid along the paracolic gutter or in the pelvis, which you can obviously see that he has none. Sorry. So after discussion with the whole surgical team, the patient, and the urology service, he has this significant left upper quadrant pain, and he also had a left-sided ureteral stone. The plan was to go to the operating room with Dr. Lang initially for a ureteral stent after a cystoscopy, and then the plan was to perform an exploratory laparotomy, evaluate his colon there given the significant pneumatosis. And then once we did that, he had these large cystic masses in the colon, which were concerning at the time. We mobilized the splenic flexure. The splenic flexure of the colon was densely adhered to the spleen, and then resected the distal transverse colon and descending colon with an end colostomy.
Sean, let me interrupt to ask you a question.
Yes, sir.
Why did you go to surgery? Was it the pneumatosis alone, or was it the clinical picture of the patient?
So the combination of pneumatosis with new onset atrial fibrillation and his right upper quadrant tenderness. So it was a constellation of things rather than just one particular finding. Yeah. It's hard to tell on the CT scan. Yeah, it's hard to tell with that, but the radiologist raised the concern with small perforation. So here are some of the images from the surgery. This is the specimen opened on the back table here. You see significant mucosal abnormality, and then these other images just demonstrate these large submucosal or subserosal gas-filled cysts. And then here's another one. I thought those were just striking images, so I thought we should include those. So postoperatively, he did well. His atrial fibrillation had resolved, and he converted spontaneously to sinus rhythm. He had return of bowel function on postoperative day 4, and his diet was subsequently advanced. The patient was, however, adamant that he not come back to the hospital for further cystoscopy and lithotripsy with stone extraction. So he underwent that, and I think that delayed his hospital stay at least a day or two. He was discharged home on postoperative day 7. He received an outpatient referral to rheumatology after more literature review because mixed or connective tissue disorders are a significant risk factor for pneumatosis. And his titers were not suggestive of Sjogren's syndrome because he had that father with Sjogren's syndrome. And then he was recently seen, I think last week, in the gastroenterology clinic for follow-up colonoscopy. He had never had a colonoscopy before, and for further evaluation for reversal. So on pathology, he had a 32-centimeter specimen, which we saw on the previous slide, with bosselated mucosa encompassing about 75% of the resection. And this is consistent with pneumatosis cystoides intestinalis. So there was no evidence of malignancy or transmural ischemia. So pneumatosis is a clinical finding or an imaging finding that was first described by Duvernoy in the 18th century. The meaning is gas within the intestinal wall. It's been known by numerous names, which makes the literature review a little bit more difficult. And there are two significantly different etiologies for pneumatosis. So one is primary, or idiopathic, which comprises 15%. So these are typically the patients who just have this on a colonoscopy. It gets biopsied, and then the cyst deflates. And then there's secondary pneumatosis, which is what we end up seeing more often in a hypotensive patient from the intensive care unit who's been in shock for hours and has mesenteric ischemia and resultant intestinal necrosis. Its pathogenesis is relatively poorly understood. There are several theories, one being mechanical, mucosal irregularity that allows this air to track in the submucosa. There's a bacterial theory, so gas-forming organisms based on a decreased mucosal protection. So gas-forming bacteria get into the bowel wall, and that's why they get these cysts. Then there's a biochemical. There are some numerous factors that play into this, such as increased fermentation of carbohydrates in the intestines. And then there's a multifactorial theory that says it's probably some of that. And then on literature review, pulmonary disease, so significant COPD, can be one of the risk factors. And so there's also the thought that maybe gas tracts from the chest down through the mediastinum into the mesenteric route, but that's very controversial. There's not really any, these people don't generally have any gas along that proposed path. And then a lymphatic theory, which was brought forth in a patient with a lymphangioma, and that was brought out, I think, the last year. So there are several key points to distinguish benign pneumatosis from this pneumatosis, which is secondary. Those include history and physical examination, laboratory evaluation. The most important things are their CBC, BMP, particularly looking at their serum potassium and creatinine, their arterial blood gas, particularly paying close attention to the pH, and then their serum lactate. And then there are numerous imaging modalities. You can sometimes see it on an abdominal plain film or a CT scan. Thought this was a very good picture. It demonstrates pneumatosis on colonoscopy here. So you see these bubble-like cysts. So that is more consistent with pneumatosis cystoides intestinalis, which is kind of the benign variant of pneumatosis. And in the recent literature, there's been significant discussion on trying to distinguish between the types of pneumatosis just based on the cystic appearance versus like a linear appearance of bowel gas on imaging. As far as the management of pneumatosis, this was historically, could be used as an indication for surgical exploration. There are several studies from the 50s and 70s and up to the 90s kind of going through case series. And then Morris et al. In 2008, they did a pretty thorough study. They looked at over 28,000 CT scans over a 7-year period, and there was a 0.37% incidence of pneumatosis. 33 of these patients underwent operation, and they had an 84% survival. Of those, 56% underwent a bowel resection for ischemia, and 13% had a lysis of adhesions. There was a 13% rate, which is pretty significant, of non-therapeutic laparotomy, and overall, the patients who underwent surgery had a 16% mortality. In their series, 50 patients were managed non-operatively with bowel rest and nasogastric tube decompression. There's some discussion in other papers regarding the utility of oxygen therapy or hyperbaric oxygen therapy even, antibiotics, and then an elemental diet. But of the patients managed non-operatively, there was a 5% mortality. And then they deemed 15 patients to be futile. So they were not offered an operation. Overall, the mortality was 22%. And then the key things I thought from the study were the preoperative creatinine, bilirubin, and lactate were all significantly higher for those patients who ended up dying. And Ferrata et al., there are two studies that have been sponsored by the AAST. One was from 2013, and that just enumerates the laboratory abnormalities that portend an increased risk of intestinal ischemia. And then this one evaluates further risk factors for pathologic pneumatosis intestinalis, and then they develop area under curve based on a bunch of rigorous statistics. So they found 79 patients with pneumatosis. 48 of those had pathologic pneumatosis. I thought it was also interesting that of the 78 patients who had benign pneumatosis, 30 were offered surgery. So there are several factors that differ between those who have a benign version or pneumatosis cystoides intestinalis and then pathologic pneumatosis. And those track along with what you would expect. So overall hemodynamic stability, presence of shock, presence of sepsis or septic shock, presence of peritonitis, and then rigidity. These also correlate with labs that you might expect, including leukocytosis, a lower hematocrit, hyperkalemia, decreased bicarbonate, elevated BU intercreatinine, elevated lactate, and then a higher INR, which is suggestive of coagulopathy secondary to sepsis. And then this other paper in Wu et al. From 2013, they presented a 70-year-old man with a history of abdominal pain, bloody purulent stool for a total of 2 years, who underwent colonoscopy and then had a barium enema. On these studies, they found submucosal cysts throughout the whole colon. He was initially treated with antibiotics and bowel rest, and then progressed to hyperbaric oxygen therapy after he had recurrence of diarrhea. Overall, he improved with observation. I think they said it took a period of about 6 months. In this study, they evaluated the Chinese literature over a 10-year period in which they found 239 cases of pneumatosis cystoides intestinalis. They found a predominance in high altitude and impoverished areas, which is, that association has not been further clarified or elucidated in any other papers that I found. And then 16% of patients developed complications, including obstruction or perforation. Thought it was very interesting that in China, the patients, particularly those with pneumatosis cystoides, most of their disease was diagnosed on colonoscopy, almost over 50%. And then 40% were just diagnosed at the time of surgery. And they found that 93% of patients had resolution of symptoms without any intervention. In this paper from this year, they also presented another 70-year-old man with a history of atrial fibrillation on anticoagulation, hypertension, cerebrovascular accident, a nephrectomy for renal cancer, and diabetes with acute onset abdominal pain and rectal bleeding, but without peritonitis, but with pneumoperitoneum on CT scan. He was observed for 6 days and subsequently discharged. Colonoscopy at an interval of 7 months demonstrated these intramural cysts, and then he was readmitted 2 months later, treated with observation, and never underwent surgery. So the interesting thing I thought about this paper is that they evaluated the international literature over the last 5 years, which found 60 cases of non-operative management of pneumatosis intestinalis. In these cases, it was predominantly secondary pneumatosis, so secondary to mesenteric ischemia or some other etiology. And the most common symptoms were abdominal pain and then imaging finding of pneumoperitoneum. And they did not find any deaths in these 60 cases. Just looking more recently, it's a pretty popular topic. In 2019, I was able to find 62 publications involving pneumatosis intestinalis. So pneumatosis cystoides intestinalis is the name that a lot of the older papers use. Some of the new papers that are talking about pneumatosis cystoides intestinalis just say pneumatosis intestinalis. So but these patients included those who are following transverse colectomy associated with alpha-glucosidase inhibitor uptake, secondary to lactulose use in a cirrhotic, a patient with aseptic meningitis, and acute generalized eczematous pustulosis who received high-dose steroids associated with perforation in a patient with rheumatoid arthritis on rituximab following adjuvant capecitabine administration for breast cancer, and then in a patient with systemic sclerosis who also had chronic intestinal pseudo-obstruction. So it's a pretty popular topic. I think it's important for us to know, kind of have a broad differential and understanding of. And then as far as cost of medicine, I like to do some of the imaging things on this because we order a lot of tests, but don't always know how much they cost. So the national average for a CT scan, $1,300, almost $1,400. Within 100 miles of Chattanooga, like scheduling an outpatient, you can have that done between $377 and $562. Abdominal x-rays are markedly cheaper. And then colonoscopy is much more expensive, which is why I thought it was pretty interesting that all of those cases of pneumatosis in China were diagnosed solely on colonoscopy. These are my references. These are some of the other papers I looked at. Happy to take any questions.
Review for us why we think he had this. What was his secondary or primary? Or?
So I think he just had primary pneumatosis. He had this kidney stone, but didn't really have any other.
Well,
signs.
you look though, he's 54. He's had a knee replacement already. He's got all this history of arthritis in his family. I mean, do we think he may be a connective tissue disorder just not recognized yet?
Yeah, I mean, that's why we sent him to the rheumatologist. The information about having Sjogren's history in the family, that wasn't told to us until he came back to the office for follow-up. So he actually is a brother of an administrator here in the hospital. So
Okay.
She relayed that to me after when they came up to the office for follow-up. I talked to the gastroenterologists, the colorectal surgeons here. Actually, the scan of the long windows is more impressive than the abdominal windows, and there were some areas of free perforation right there.
So the reason, though, to take him to surgery was not the pneumatosis as much as the perforation,
Yeah,
right?
he has some perforations, some micro perforations in that area.
That's why we felt we needed to operate.
That along with, didn't know if this was from ischemia, throwing a clot from AFib, even though his lactate was normal, but I've seen that power with normal lactate. And, or, you know, the imaging is very impressive. And talking to a gastroenterologist, this is something that we don't see often here. And honestly, this is the first time that I see this particular picture in 15 years. And I talked to the colorectal guys, and they haven't, you know, they didn't have either a lot of knowledge of this. So I thought it would be interesting to see it here. It's different than the pneumatosis that you see from ischemia, because this is like through cyst in the intramural cyst. And yeah, they're diagnosed with colonoscopy most of the time. And etiology, it can be post-chemotherapy, but he never had chemotherapy. It can be immunologic disorders or connective tissue disorders. There are some substances that are associated to this. The ethylene is associated to this, but I haven't seen any. It's also seen in COPDers. And
he smokes packing half a day. And
so it used to be an entity that used to be more common in the small bowel, but now it's more common in the colon. And you could see this in the duodenum, but now 60% of the cases are encountered in the colon. And COPDers will do that, and that's one of the reasons to try to treat this with hyperbaric oxygen. So,
well, a 54-year-old who's got atrial fib and had a knee replacement. I mean, he's not exactly a healthy guy. I mean, this guy's got a lot of problems. Dr. Stanley, I want to ask, what about C. diff? I mean, our national expert on C. diff, is this something that we see with it?
Not so common with C. diff, but it is for colidities such as inflammatory bowel disease.
Okay.
And so you could get that with toxic megacolon with just about any any type of colitis. But I think one thing that this does bring up is you have to treat the patient clinically, and it sounds like, especially if you have somebody with a stone and it looks like perforation, I think you got about do what you did. But in retrospect, do you think that you needed to take the colon out? I'm not questioning your judgment at all. I think I would have done the same thing, but just...
When we got in there, and I thought about, should we take the whole thing out? I didn't know what I was dealing with, to be honest. So he was already perforated. So if it was a cancer, it was already perforated. So we took that segment to get some specimen. Didn't hook him up because I didn't know what it was. So that's why I gave him a colostomy. But we thought about that, but we resected what macroscopically looked disease. And in case, if it was a malignancy, it was already perforated, it would get chemotherapy and a colonoscopy. So.
Dr. Moore?
I had a very good presentation. I had one question that seemed to be answered on one slide with one person that seemed to have follow-up colonoscopy. So treat somebody non-operatively, and this is, the area he was in was a watershed area. He's a smoker. If he's got a vascular issue, you're kicking a can down the road. And I didn't see all the data on, okay, you're a year out, you follow him up, and he's still got the same thing. So at what point do you decide where he starts coming back that you simply have to do something?
Yeah.
Based on, we see it, but it doesn't seem to be bothering him right now.
And now you're talking about the cystic change in the...
Yeah, when you non-operatively manage a guy and then you go back and the stuff still looks the same.
Yeah. What about it?
Right. I didn't find that anywhere in the literature. Pretty much everything has been a case report, and then they'll review recent cases. But I think if the patient continues to come back with nonspecific abdominal pain, you discuss the risks of surgery. And I didn't find any data that kind of enumerated a risk of malignancy associated with this. So you'd want to counsel the patient extensively, but if they're worried about it over time and it's still there on repeat colonoscopy or repeat imaging, I think you could offer an operation.
I think one of the things, the symptoms of this entity is diarrhea. So these patients will continue with diarrhea, and honestly, I don't know at what point you go ahead and just say, let's go do a colectomy and take care of the problem. So.
When somebody has peritonitis and they've got a hole in their bowel, you don't ever have to apologize for operating on that patient, I think. And I think that was your point, Dr. Mejia. And I agree, I would have taken it out myself, but you just didn't know why you were there exactly at that time. Sick patient needs an operation. Okay, two great cases. Thank both of you very much. Excellent review. We will adjourn. As I said, folks, we got to go up to the fourth floor for further discussion. Thank you very much. Good job, guys.